Myself, Dr. Harish Mallaprama Ishwarappa. Today I am going to discuss a major aspect of COVID 19, that is multi organ involvement, particularly in critically ill COVID 19 patients. What we know in terms of evidence and what currently we have the experience. Previously, I discussed in relation to COVID 19, that is pathophysiology and its ventilatory management, supportive care in intensive care unit. Today, maybe in another 25 to 30 minutes, we'll stick on to multi-organ involvement in critically ill COVID-19 patients. So already we know that cytokine storm is the trigger for organ involvement in COVID-19. So when COVID-19 enters through the respiratory system, it is going to act on the B cells which produce some antibodies that will appear in the bloodstream after 7 days, and it also acts on the T cells, so which in turn release inflammatory mediators through the neutrophils, that is interleukin 6, 1 and TNF alpha, and also it involves the complement system also. But you have to remember this huge cytokine storm, again it will act on the lung to give rise to interstitial edema and the pathophysiology of the ARDS. So when it comes to the overall spectrum of COVID-19, so it is the different severity, different stages, the same spectrum of disease. Maybe initially, so they have limited organ manifestation, maybe just they have fever, cough and breathing difficulty, or they can have atypical manifestation with a gut involvement like diarrhea with some particular signs and symptoms. When they move to different stages, there will be surge of inflammatory cytokines that we call it as cytokine storm. Then there will be possibility of the organ involvement and multi-organ dysfunction. So the therapy is also been supportively targeted on different stages and different severity and different organ involvement in COVID-19 patients. So again, there is one more link why there will be more organ damage in a critically ill COVID-19 patient. That is the link between ACE2 receptors and COVID-19 spike protein. We know that ACE2 receptor is essential for some physiological benefits in the body, like it helps in anti-atrophy, anti-fibrosis, anti-inflammation, antioxidant and vasodilatation. So overall it helps in tissue protection. So when there will be attachment of spike protein of the COVID-19 with the ACE2 receptor, there will be further down regulation of this protective ACE2 receptor, so which leads to increased atrophy, fibrosis, pro-inflammation, oxidative free radical injury and vasoconstriction. So this attachment is going to be activated by an enzyme called transmembrane protease serine 2, which helps in binding of spike protein to ACE2 receptor. Now the question is these ACE2 receptors are restricted only to lung? That is not the scenario, because they expressed in heart also. That's why they have different manifestation like cardiomyopathy, congestive heart failure and atherosclerosis. They also manifest in intestinal epithelium. That's why they have gastrointestinal manifestation, vascular endothelium with endothelial injury and exposure of subendothelial collagen tissue, different manifestation of ischemia and thrombus, acute kidney injury because of the expression of this ACE2 receptor in the kidney also. So basically, in critically ill patient, COVID-19 can involve different organs from the cardiovascular, renal, neurological. They can have vascular involvement, gut involvement, cutaneous, and purpura fulminans along with the liver, which can manifest as transaminases. So this is the worst fate of COVID-19. Again, if you see the incidence, we know that 80% of the COVID-19 patient doesn't require any sort of ICU admission. So they don't even require the hospital admission. Also, among 20% who required hospitalization, about 5% will require ICU care. In that 5%, near about 25 to 30% will have ARDS. Viremia can occur in about 15% of the patients. So in another 15% they have acute kidney injury. This is an gross estimation of acute kidney injury. So again around 12 to 15% can have cardiac involvement. So in about 10% they can have secondary bacterial infection leading to severe sepsis and septic shock. So this is the overview of multi-organ involvement with the current available evidence. So we'll go one by one. So how this exactly manifest with a multi-organ involvement in critically ill patients. Again, first, so if it comes to gut manifestation of COVID-19, so this is the descriptive cross-sectional multi-center study from China. So they analyzed the patients in between February and January, so 2020, in the beginning of this pandemic era. So all the patients were confirmed with real-time PCR. They analyzed near about 204 patients with positive COVID-19. Among them, near about 50% of the patient had digestive symptoms. So if we exclude the most non-specific symptom, that is lack of appetite, which occurred in about 80% of the patients, if we include only diarrhea, vomiting and abdominal pain, so near about 19% where the patients presented with GI specific symptoms. So this is the breakdown of different symptomatology and the percentage. So if you see 9% of the patient, they don't have either digestive or respiratory symptom. About 3% had standalone digestive symptoms, but they don't have any respiratory symptom. So near about 40% of the patients with a respiratory symptom without any digestive symptom, and 47% of the patients they had both digestive and respiratory symptoms. So lots of atypicality is there in the presentation of this COVID-19 in critically ill patients. Again, these are the some basic biochemical characteristics of the patients who had gut symptoms. So there was neutrophil count was elevated, but they had lymphopenia, decreased monocyte count. Again, overall, so patients with digestive symptoms had higher mean liver enzyme level, lower monocyte count, longer prothrombin time, and received more antimicrobial treatment than those patients without digestive symptoms. So again, one important aspect they identified, those patients who had any of the gut symptom manifestation, they reached the hospital or healthcare facility little bit late as compared to the patients without digestive symptoms. Because in the beginning, nobody was able to understand this atypical presentation of COVID-19. That might be the reason why they not rushed into the hospital. So they might have thinking something different may cause this gut manifestation. So as the severity of the disease increased, digestive symptoms become more and more pronounced in these group of patients. Again, one other important like clinical manifestation in terms of different organ involvement in COVID-19, there is a thrombotic complications. So one data again came in the mid-March. So they analyzed composite outcome of symptomatic all thrombotic complication. Maybe it is acute pulmonary embolism, deep venous thrombosis, ischemic stroke, myocardial infarction, or systemic arterial embolization. So they prospectively evaluated in 3 Dutch ICUs. So near about 184 ICU patients with a COVID positive. Among them, so 13% of the patients died. So all the patients received some sort of standard thromboprophylaxis. So as per their indication and contraindication, the cumulative incidence of composite outcome was about 31%. So the risk factor for having this thrombotic incidence was elderly age and those patients who had coagulopathy. So this is the breakdown. So near about 25 patients had pulmonary embolism. So 3 patients had thromboembolic manifestation of lower limb or upper limb. 3 patients had some sort of ischemic stroke. So it suggests there is a significant burden of the thrombotic events as a manifestation of organ involvement in critically ill COVID-19 patient. So this manifestation increases as the length of ICU stay increases. So proportionately, when the length of stay increases, the number of these thrombotic events were also increased. So again, one more organ system which worried in the COVID-19 patients is pulmonary embolism. So this is the initial patient reported. So maybe in the mid-March. So he was a 42-year-old male patient. So without recent travel or no significant medical history, presented to emergency department with a worsening chest pain, shortness of breath and hemoptysis. This was the ECG which shows some S1Q3T3 pattern with a sinus tachycardia. So again this is the CTPA which shows clearly segmental clot. So in the same time CT thorax shows ground glass opacities bilaterally. So it suggests COVID-19 can cause severe pro-inflammatory cytokine surge and hypercoagulable state with the elevated markers like LDH, ferritin, C-reactive protein, D-dimer, interleukin level, and hyperfibrinogenemia and fibrin degradation products. So the confusion is when a patient initially present with some sort of respiratory symptoms in and around ARDS and COVID-19 induced pulmonary embolism, there will be lots of diagnostic dilemma will be there, and we can't jump on getting like CT pulmonary angio because of the logistic involvement, and if they have already existing acute kidney injury, so like with the risk of contrast induced nephropathy. So hemoptysis generally it appears about 13% of the pulmonary embolism patients, but it is infrequently reported among COVID-19 infections. So again, the most common ECG finding in pulmonary embolism, that the right heart strain was not appeared in COVID-19 like pulmonary embolism. So again, there is a data suggest that patients who received some anticoagulation had a outcome benefit. So one more aggressive like manifestation of this COVID-19 is catastrophic antiphospholipid antibody syndrome and coagulopathy. It is in concern with connective tissue involvement. So initially we got a report of 3 patients from Wuhan, China. So if you see the demographic data of all these 3 patients, they were all elderly. So with some comorbidities like hypertension, diabetes or previous stroke. So they had some sort of symptoms which are narrow to COVID-19 like fever, cough and breathing difficulty. So imaging shows ground glass opacities. So they received some antiviral and other supportive therapy. So again, so if you see the severity, all the patients were sick enough to need the ICU care. So this is overall the manifestation is they had bilateral lower limb ischemia. CT brain showed bilateral cerebral infarcts with multiple vascular territories. All of them were needed mechanical ventilation. So biochemically they had leukocytosis, thrombocytopenia, elevated PT and APTT with the elevated level of fibrinogen and D-dimer. So again there is some more hint this COVID-19 can manifest as catastrophic procoagulant status in critically ill area. So again, what about the one other important organ, that is cardiovascular system? So initially we got lots of data from Spain and Italy. Even young patient died with a sudden cardiac arrest. So the proposed mechanism they attributed it to myocarditis. So if you see the incidence of shock, patients with COVID-19 at the time of admission, they don't have any manifestation of this shock. Even among critically ill patient, blood pressure was normal. The lactate were like minimally elevated or maybe normal. So troponin elevation in COVID-19 patient, like especially high sensitivity troponin as acted as a predictor of mortality. So among the non-survivors, this troponin level like stayed in the blood from day 4 up to day 22. So again, these patients, they don't even have like respiratory involvement also. So troponin level, so different reasons in COVID-19. So it may be because of myocarditis. It is a rare cause, that is a type 1 myocardial infarction because of the plaque rupture. This is the least common cause. Again, type 2 myocardial infarction is a supply demand mismatch between the oxygen supply and that of the myocardial oxygen consumption. So stress cardiomyopathy, it is because of the increased sympathetic drive, what we call Takotsubo cardiomyopathy, that may trigger the increase in troponin level, or it may be direct viral injury which leads to viral myocarditis and cardiomyopathy. So again, this cardiomyopathy can have fulminant manifestation which may attribute to mortality somewhere between 7 to 33%. So this may be a late feature. Even in the patient who had subsided with a respiratory symptom, they can still have cardiomyopathy. It is unclear whether this represents a viral cardiomyopathy, stress-induced cardiomyopathy, that is Takotsubo cardiomyopathy, or cardiac dysfunction secondary to secondary hemophagolymphohistiocytosis or cytokine storm syndrome. So again, some more data. So initially in the mid-March we got, so they analyzed near about 137 subject. So near about 7.3% of the patient, they presented with palpitation as one of their initial symptom to the outpatient department. So in one more data, so near about 140 patient they included. So COVID-19 induced arrhythmia has been reported in about 17% of general cohort and in about 44% in patients who got ICU admission. So again, the specific cause for this palpitation or type of arrhythmia were not specified. So they proposed that maybe hypoxemia, electrolyte imbalance, or maybe viral myocarditis may be the cause for arrhythmia and palpitation manifestation in critically ill COVID-19 patient. Again, about the circulatory shock, I initially told, so the patients with COVID-19 usually will not present with like shock in the time of admission. If at all it happened, it may be secondary to myocarditis with cardiomyopathy, secondary to bacterial infection during the stay if they got mechanically ventilated. So it may be a gram-negative sepsis. It is hardly less than 8 to 10%. Maybe severe cytokine storm or secondary HLH syndrome. So obstructive shock because of the hypercoagulable state induced pulmonary embolism. So pulmonary hypertension due to excessive like mean airway pressure which compromises the venous return because of the PEEP, or it may be anaphylactic reaction to some antiviral medications, excessive fluid restriction because we know that ventilate these patients with a severe fluid restriction, keep them on negative fluid balance. If the patient had some gut manifestation with a severe diarrhea, if you restrict the volume in them, they can have the circulatory shock. Again, when it comes to renal involvement, if you see the incidence, it is varied in terms of overall incidence. So if you see general incidence of this acute kidney injury in ARDS patient is somewhere around 65%. In COVID-19 patients with the ARDS, it is varied because of the different group of population, different number of populations involved in the study, but grossly the estimate may be in and around 15% among hospitalized patients with COVID-19. Again, what is the pathophysiology? So I already discussed it in one of my previous video. So it is multifactorial. Acute kidney injury can happen in COVID-19. It may be because of cytokine damage. So because of the cytokine storm, so it is going to cause some sort of peripheral vasodilation, decreased renal perfusion pressure. So again, if the patient is on some extracorporeal circulation like ECMO or CRRT, it will lead to again cytokine surge. The patient on mechanical ventilation, it can cause biotrauma to the lung. So again, lead to increase in cytokine release, or it may be HLH syndrome. So we know that organ crosstalk is also true in COVID-19 patient. The patient is having viral myocarditis with cardiomyopathy with a low contractility. There will be back pressure generation which cause renal venous congestion. So then it leads to cardiorenal syndrome type 1. So along with they can have a decreased cardiac output which trigger the renin-angiotensin system also. Because of alveolar damage, severe hypoxia which lead to renal medullary hypoxia and acute kidney injury. High peak airway pressure, intra-abdominal pressure can cause renal compartment syndrome with a compromised renal perfusion, or many patients with a COVID-19 can have skeletal muscle injury with an elevated CPK level, so which leads to rhabdomyolysis and pigment nephropathy and tubular toxicity. So other reason, it may be because of positive fluid balance with a renal compartment syndrome or breaching endothelium. So because of positive fluid balance, again I told in about 8 to 10% they can have secondary bacterial infection, particularly gram-negative organism, which leads to endotoxin release and sepsis AKI in COVID-19 patients. So one more interesting feature in this COVID-19 patients, those who have acute kidney injury, they have significant proteinuria and hematuria, which may maybe in and around 40 to 60% of patients. So does this acute kidney injury in COVID-19 is having a bad prognosis? Definitely yes. If the acute kidney injury stage increased from 1 to 3, almost the mortality is going to be increased by 2 to 3 times again. So risk of mortality is going to be doubled in patients those who died with the acute kidney injury as compared to the survivors. It's not only the mortality, so cardiovascular morbidity is going to be increased on long term basis if the patient had COVID-19 induced AKI. So overall the incidence may vary from 0.5 to 30%, more common in ICU setting. So near about 0.8 to 17% of the patient they need CRRT. They can have albuminuria and hematuria. Patients with comorbidities like cardiovascular disease, chronic kidney disease, hypertension and diabetes are the risk factor to develop acute kidney injury secondary to COVID-19. Again, what about the one more important organ when it comes to multi-organ involvement, that is CNS manifestation? They can have hemorrhagic or ischemic infarct. Why hemorrhage? I already told, because of the interaction between ACE2 and S protein. So the ACE2 receptors are going to be down-regulated, which was already there in hypertensive patient. They can have hypertensive crisis, along with if they have coagulopathy with a prolonged PTT and PT, they can have hemorrhagic infarct. What about ischemic infarct? I told COVID-19 can cause endothelial damage with increase in D dimer and procoagulant status. They can have cerebral venous and arterial infarction, particularly because of the ischemia. So again, this is the data which published from China, Wuhan in the beginning of 2020. So near about they studied 214 patients with COVID-19. So near about 36% of the patient had some sort of neurological manifestation in terms of headache, dizziness, or acute cerebrovascular disease or impaired consciousness. Among these patients, so near about 19% of the patients required ICU care with some intervention for their severe neurological involvement. So this is the typical CT showing infarct in patients with COVID-19. At the same time, if you done a CT imaging of the lung, which shows bilateral ground glass opacity. So again, overall, so the incidence of stroke is about 5%. So impaired consciousness occurred in about 13% of the patients. The skeletal muscle injury with a rhabdomyolysis with elevated CPK can occur somewhere around 17% of the patients. So is this COVID-19 can present with encephalopathy? Yes, this was initial report. So in an elderly gentleman with some comorbidities like previous cardioembolic stroke, atrial fibrillation, Parkinson's disease, COPD, so recent treated for cellulitis, he presented to emergency department with some sort of fever and cough. If they evaluated, patient had ground glass opacities. So CT brain doesn't show any new infarct. CSF analysis was normal. When they done the EEG, which shows typical picture of encephalopathy. So we have to remember in elderly patient with some sort of comorbidities, COVID 19 can manifest as encephalopathy with a background of their critical illness. So, there is one more entity we have to remember. COVID 19 can manifest as severe cytokine activation syndrome. So, a subgroup of patients with severe COVID 19 have cytokine activation and secondary hemophagocytosis and lymphohistiocytosis syndrome. Patient who had cytokine activation developed rapid progression to ARDS, shock, and multi organ failure. So, if it comes to pathophysiology, neutrophil activation and pro inflammatory cytokines likely contribute to multi-organ involvement with the ARDS. That was true in patients with initially presented SARS and MERS. So COVID-19 confirmed patients with ARDS have higher neutrophil counts. So on an average about 7%, those without ARDS about like 3%. It almost doubles the incidence of ARDS with a patient with high neutrophil count and pro-inflammatory cytokine response. Again, what about cytokine activation syndrome? So we need to diagnose this secondary HLH in patient. We need to work up. So with a suspected clinical deterioration with a shock and other organ involvement, to do CBC, differential count, PTA, PTT, INR, fibrinogen level, D-dimer, ferritin, liver function test, triglyceride, and C-reactive protein. To calculate the score, that is H score, which include different parameters with a different value. If the cutoff value is more than 169, we have to have a strong suspicion of this secondary HLH with a background of COVID-19 and critically ill patients. So what about the management of the cytokine activation syndrome? So there are lots of speculation. Might patient might get benefit with some sort of immunosuppression, but we have to wait for lots of evidence before we jump on IV agenda. But as like other patients with a secondary HLH, we can give steroid or etoposide, but you have to remember any chemotherapy can suppress their marrow, so can have cytopenia. We can try some sort of cytokine absorption like cytosorb in these patients with a severe cytokine activation syndrome in critically ill area. So again, so secondary HLH is an under-recognized category, and in adults it is most commonly triggered by viral infection. It is not a newer entity only narrowed to COVID-19. Even a dengue patient, H1N1 pneumonia patient can also trigger secondary HLH. Even in sepsis patient, the incidence is somewhere around 5%. So when we need to suspect secondary HLH, the patient is having an unremitting fever, bicytopenia, increased ferritin level, pulmonary involvement in terms of ARDS. So if there is any of these manifestation, near about 50% of the patient can have secondary HLS. So patient with elevated ferritin and interleukin 6, these are the two predictors of poor outcome with the background of secondary HLH with a high mortality. So again, patient with COVID-19, one interesting thing, organ involvement is like cutaneous manifestation. This is the data from again from the Italy. They analyzed and the hospitalized patient of Lombardy, Italy, which was most badly affected in Europe because of the COVID-19. They analyzed near about 148 positive patients. Finally, they excluded 60 patients because these patients were already received some sort of medication in the previous 15 days. They don't want to get confounded by these medicine induced skin manifestation. Among the remaining 88 patients, near about 20% developed cutaneous manifestation. 8 patients had on the day 1, 10 patients developed after admission. So if you see the distribution, it was truncal, like extremities, so multi-site involvement. They can have urticaria, acral ischemia, morbilliform rashes, petechial, vesicular, or it may be livedo reticularis. So multiple involvement, so multiple manifestation in terms of cutaneous manifestation in COVID-19, but they were not able to show any correlation with the disease severity and this cutaneous manifestation. When it comes to extreme cutaneous dangerous manifestation is purpura fulminans with a digital ischemia and gangrene. So it's a prothrombotic form of DIC. So, in a patient who is having some sort of deranged coagulopathy, coagulation factor with the elevated D dimer, we have to have a high level of suspicion of this purpura fulminans, because we need to give very high dosage of heparin in these patients because they have already decreased antithrombin 3. So then this heparin requirement is going to be elevated. We can try some topical nitroglycerin or maybe intravenous prostaglandin to cause some sort of vasodilatation to give symptomatic relief in this COVID-19 patient with purpura fulminans. Again, we know that the overall fate of this cytokine storm, they can have recovery if you support them adequately. If it become uncontrolled, so they can have this severe cytokine storm with a multi-organ involvement as a trigger, lung as a central trigger. So they can have secondary bacterial infection. Again, if you support them adequately, there is a chance of recovery or they might die. So again, this cytokine storm can again cause injury to the lung. So it is vice versa with again the release of this pro-inflammatory cytokines. So therapy, again, it is questioned like should we stimulate or suppress the immune response in COVID-19 patients with cytokine and anti-cytokine interventions. This is a review not yet published. So if you see, the therapy depends upon the severity of the patient. The patient is mild and moderate disease, his level of inflammatory cytokine will gradually decrease over the time. But if the patient is having a severe disease manifestation, its load of interleukin 1, TNF alpha, and interleukin 6 is going to be severely elevated. So the intervention opportunity depends upon the severity of the patient and what we need to target. Suppose if the patient is in the initial manifestation, so we need to give them type 1 interferon or interleukin 7, so which are beneficial. If the patient is manifested severely, we have to target IL-1, interleukin 6 or TNF alpha or JAK inhibitor as some sort of supportive therapy to curb this pro-inflammatory cytokine level. Overall, to conclude, so it is the play this COVID-19 with the background of lack of clear and specific clinical symptom. It is very difficult to diagnose in the beginning. So it can have multiple organ involvement or it may present with atypically. It may not have any symptoms at all. If it has some organ involvement, it may be because of the inflammation with a cytokine storm, or it may be direct viral injury, or it is because of the procoagulant state with a microthrombi. So any of these pathophysiology can individually manifest, or it may be mix of all these pathophysiology which leads to multi-organ dysfunction. So our goal is, as long as we don't have any specific proven therapy or the vaccine, we have to try to curb this cytokine storm. So it is a supportive therapy. It is still we are in the phase of understanding and learning the pathophysiology of the COVID-19. So we try to target pathophysiology when we don't have specific therapy. It may be like targeting the cytokines, immunomodulation, antioxidant, anti-inflammatory agent. But each day is evolving. We are getting more and more newer data, newer evidence, newer experience across the globe. We have to wait what exactly is going to work in this multi-organ involvement in COVID-19 patient. Till then, it is supportive care. So lastly, we have to remember, so one facet of this COVID-19, what we are targeting currently in the research is like we are trying to find out some sort of antiviral. Other facet of this pathophysiology like pro-inflammatory cytokines that we can still manipulate with some sort of supportive care. Thank you all. So please subscribe to my YouTube channel to watch more and more educational videos.